Hello everyone. Today we will be discussing one of the most essential clinical assessment tools in neonatal medicine, the new Ballard Score. This standardized instrument plays a crucial role in determining gestational age in newborns, particularly when prenatal history is unavailable or unreliable. Let's explore its framework, applications, and clinical significance. The new Ballard score, abbreviated as NBS, is a standardized clinical instrument specifically designed for estimating gestational age in newborns. Originally developed by Dr. Gene L. Ballard in 1979 and subsequently expanded in 1991, this assessment tool has become indispensable for identifying at-risk infants when obstructive dating proves unreliable. What makes the new version particularly valuable is its refined utility. It has been specifically adapted to assess extremely premature neonates, extending the assessment capability down to 20 weeks of gestation. This expansion has been crucial in modern neonatal care where we are increasingly managing very early preterm infants. The NBS framework is fundamentally based on predictable patterns of fetal maturation. It assesses two primary categories: neuromuscular maturity and physical maturity. The scoring system ranges from -10 to +50, with these scores directly correlating to gestational age in weeks. This systematic approach provides clinicians with objective, reproducible data for critical decision making in neonatal care. Let's examine the comprehensive framework of the new Ballard score. Starting with purpose and principles, the primary objective is to accurately estimate newborn gestational age using assessment of both physical and neuromuscular maturity. This tool helps us identify risk factors and guide appropriate interventions. It's based on the fundamental principle that fetal maturation follows a predictable sequence, allowing for standardized assessment. Regarding historical context and evolution, as mentioned, Dr. Ballard developed this score in 1979 with a significant expansion in 1991 to better accommodate preterm neonates. The scoring system was simplified from the Dubovich method for easier bedside use, and importantly, it added lower scoring tiers with a -1 category to assess extremely premature infants. The neuromuscular maturity component evaluates six key parameters: posture, arm recoil, scarf sign, square window, popliteal angle, and heel to ear maneuvers. Each of these reflects the developing tone and flexibility of the neuromuscular system. The physical maturity component similarly assesses six parameters: skin texture and appearance, plantar surface development, eye and ear cartilage formation, lanugo distribution, breast tissue development, and genital maturation. Regarding application and timing, the assessment should ideally be performed within the first 96 hours of life, though it remains valid up to 7th day. Accuracy is highest within the first 48 hours. For optimal results, the new Ballard score should be integrated with other clinical measurements and obstetric data. The new Ballard score serves four primary clinical applications. First, estimating gestational age. We utilize the NBS when obstetric dating is unavailable, unreliable, or uncertain. It provides confirmation of gestational age, which is especially critical for premature births where accurate dating directly impacts clinical management decisions. Second, assessing preterm risk. Precise gestational age determination via the NBS is crucial for identifying newborns at heightened risk of morbidity and mortality due to prematurity. Early identification allows for appropriate resource allocation and anticipatory guidance. Third, guiding medical care. The NBS provides essential gestational age data that enables healthcare workers to plan and implement appropriate neonatal interventions and specialized care protocols tailored to the infant's developmental stage. Fourth, research and tracking. Standardized gestational age assessment contributes to epidemiological data, aiding in tracking preterm birth prevalence and informing public health strategies at local and national levels. Now let's examine each neuromuscular maturity component in comprehensive detail, including specific scoring criteria and clinical technique. First, posture. This assesses the infant's preferred resting position when undisturbed and supine. The scoring progression is quite specific. At the earliest gestational ages, around 20 to 24 weeks, infants exhibit completely extended posture of all extremities, scoring -1. As maturation progresses, we observe sequential development of flexion. By 28 to 30 weeks, there is slight flexion of the lower extremities. At 32 to 34 weeks, we see moderate flexion of both arms and legs. By 36 to 38 weeks, Strong flexion of the lower extremities is present with moderate upper extremity flexion. Finally, at term 38 to 40 weeks and beyond, we observe full flexion of all four extremities with arms tightly flexed and hands obtained in fisted positions. This progression reflects the cephalocaudal and proximo-distal development of muscle tone, with the lower extremities developing flexor tone before upper extremities. Second, arm recoil. This is dynamic assessment of flexor muscle tone and require careful technique. The examiner first flexes both of the infant's forearms against the upper arms for approximately 5 seconds to condition the muscles. Then briefly extend the arms fully and quickly release them simultaneously. In very premature infants below 28 weeks, there is no recoil. The arms remain extended, scoring -1 or 0. Between 28 to 32 weeks, we observe sluggish, partial recoil to approximately 90 to 100 degrees of flexion. At 34 to 36 weeks, there is moderate recoil to 90-degree angles. By 38 weeks, we see brisk recoil to approximately 110 to 140 degrees. At full term, there is immediate complete recoil with forearms returning rapidly to full flexion against the upper arms, obtained with resistance to re-extension. This test is particularly valuable because it is relatively objective and less influenced by infant state than some other neuromuscular signs. Third, scarp sign. These evaluate shoulder girdle tone and flexibility. Technique is important. With the infant supine, take the infant's hand and pull the arm across the chest toward the opposite shoulder, applying gentle but firm traction while supporting the elbow. Observe how far the elbow travels across the chest relative to anatomical landmarks. In extremely premature infants of 22 to 26 weeks, the elbow crosses well past the opposite axillary line, scoring -1. At 28 to 30 weeks, the elbow reaches the opposite axillary line. At 32 to 34 weeks, the elbow reaches only to midline. At 36 to 38 weeks, the elbow remains between midline and the ipsilateral axillary line. At term 40 weeks and beyond, the elbow does not reach midline, remaining close to the same side shoulder with significant resistance. You should feel increasing resistance as a gestational age advances, reflecting developing shoulder girdle and trunk muscle tone. Fourth, square window. This assesses wrist and hand flexor tone by evaluating the angle between the palm and forearm. Proper technique requires gentle but firm pressure with the infant's forearm stabilized. Apply gentle pressure with your fingers on the back of the infant's hand, flexing it toward the forearm without forcing. The scoring is angular. At less than 26 weeks gestation, you cannot achieve flexion beyond 90 degrees. The angle remains greater than 90 degrees, scoring -1. At 28 to 30 weeks, you can achieve a 90-degree angle. At 32 to 34 weeks, the angle decreases to approximately 60 degrees. At 36 to 38 weeks, you can achieve a 45-degree angle. At 40 weeks, the angle approaches 30 degrees. Finally, a post-term gestation, you can flex the hand flat against the forearm, essentially 0 degrees, reflecting a maximum flexor tone development. This is one of the most reliable neuromuscular signs for gestational age assessment. Fifth, popliteal angle. These measures hamstring flexibility and leg flexor tone. The technique requires careful positioning. Place the infant supine, stabilize the thigh on the abdomen with one hand with the hip fully flexed at 90 degrees. Then gently extend the leg at the knee with your other hand until you meet definite resistance. Measure the angle behind the knee, the popliteal angle. Do not force extension. At 24 to 26 weeks, the leg extends nearly completely with popliteal angle of 180 degrees. At 28 to 30 weeks, the angle is approximately 160 degrees. At 32 to 34 weeks, it decreases to about 130 to 140 degrees. At 36 to 38 weeks, the angle is approximately 110 degrees. At term 40 to 42 weeks, the popliteal angle is typically 90 degrees or less with a significant resistance to further extension. This reflects progressive development of hamstring and lower extremity flexor tone as pregnancy advances. Sixth, heel to ear. This final neuromuscular parameter assesses hip flexibility and overall lower extremity tone. The techniques involves with the infant supine and pelvis flat on the examination surface, gently pull the infant's foot toward the ipsilateral ear, keeping the pelvis flat, do not lift the buttocks. Observe both how close the foot comes to the ear and degree of knee extension that occurs. Also note the resistance you encounter. In very premature infants at 24 to 26 weeks, the foot reaches the ear easily with the knee remaining extended, scoring -1. At 28 to 30 weeks, the foot comes very close to the ear. At 32 to 34 weeks, the foot reaches approximately to the level of the nose or mouth. At 36 to 38 weeks, significant resistance is encountered and the foot only reaches the chin level with the knee beginning to flex. At term 40 weeks and beyond, there is marked resistance. The knee flexes significantly and the foot reaches only to the upper chest or shoulder level, now nowhere near the head. This maneuver is assesses both hip flexor and extensor balance. Remember, all neuromuscular assessments should be performed when the infant is quiet and in a neutral behavioral state. Not crying, feeding, or sleeping deeply. Active crying or agitation can falsely elevate tone, while deep sleep or sedation can falsely lower scores. The infant should be warm and comfortable throughout the examination. Let's now review the 6 physical maturity parameters with the detailed scoring criteria and examination techniques. First, skin. This assessment evaluates both texture and transparency, reflecting epidermal development and keratinization. The progression is tracking. At 22 to 24 weeks gestation, the skin is sticky, fragile, and transparent. You can easily see blood vessels through it. This scores -1. At 26 to 28 weeks, the skin becomes gelatinous and translucent with visible veins, particularly over the abdomen and chest. At 30 to 32 weeks, the skin is smooth and pink with few visible vessels. It's no longer transparent. At 34 to 36 weeks, the skin shows superficial peeling or mild cracking, particularly on hands and feet with rare visible vessels. At 38 to 40 weeks, the skin demonstrates cracking and peeling, especially over the extremities with no visible vessels. The skin appears pale pink or pale. Finally, at postterm gestation beyond 42 weeks, the skin becomes leathery, cracked, and deeply wrinkled with parchment-like texture, particularly noticeable on hands, feet, and ankles. This reflects progressive cornification of the epidermis and decreased subcutaneous edema with advancing gestation. When examining, look at multiple body areas including abdomen, chest, arms, and legs. Second, plantar surface. This is one of the most reliable and objective physical maturity signs. It assesses the development of the skin creases on the sole of the foot with reflect dermal maturation. The examination technique is straightforward. Measure the infant's foot length from heel to the longest toe. This is important because foot size correlates with the assessment accuracy. Then carefully observe the sole for creases. At less than 28 weeks gestation, when the foot is typically less than 40 millimeters, the sole is completely smooth with no creases visible, scoring -2. At 28 to 30 weeks with the foot length 40 to 50 millimeters, faint red marks appear. These are precursors to creases, scoring -1. At 32 to 34 weeks, you observe anterior transverse creases only. These are fine lines across the ball of the foot with the posterior two-thirds remaining smooth. At 36 to 38 weeks, creases extend to the anterior two-thirds of the sole. At 40 weeks, the term creases cover the entire sole from heel to toe, though they may still be relatively superficial. Finally, in postterm infants beyond 42 weeks, the entire sole demonstrates deep creases and indentation. An important caveat: in extremely growth restricted infants or those with intrauterine stress, plantar creases may develop prematurely, potentially overestimating gestational age. Third, eye and ear. These are actually two separate assessments combined. For the eyes, at less than 24 weeks, the eyelids are fused shut, scoring -1. At 24 to 26 weeks, the lids are opening with visible eyebrows and lashes beginning to form. By 28 weeks and beyond, eyes are fully open with well-formed lashes. For the ears, we assess cartilage development and pinna shape. Technique: fold the pinna of the ear forward against the head, then release it and observe the recoil. At 24 to 26 weeks, the pinna is flat, shapeless with no cartilage. It stays folded with no recoil, scoring -2. At 28 to 30 weeks, the pinna shows slight incurving of the superior edge with minimal cartilage. Slow recoil occurs. At 32 to 34 weeks, well-curved pinna with chopped but ready cartilage is present. The ear unfolds after being folded but no instantly. At 36 to 38 weeks, the pinna is firm with instant recoil. It springs back immediately when released. At term 40 weeks and beyond, thick cartilage is present with firm, well-formed ear that has distinct incurving and immediate strong recoil. The ear assessment is particularly valuable because it is unaffected by infant state or examiner technique variability. Fourth, Lenigo. This fine downy body hair follows a predictable developmental pattern. At 20 to 22 weeks gestation, Lenigo is absent because it hasn't yet developed. At 24 to 26 weeks, sparse Lenigo appears primarily over the back. At 28 to 30 weeks, abundant Lenigo covers the entire back, shoulders, and upper arms. This is the peak of Lenigo development. At 32 to 34 weeks, Lenigo begins thinning, particularly over the lower back, but remains abundant over the shoulders and upper back. At 36 to 38 weeks, Lenigo is sparse with bald areas clearly visible, persisting mainly over the shoulders. At term 40 weeks and beyond, Lenigo is mostly absent, though occasional fine hairs may be present over the shoulders in some infants. The examination should be performed in good lighting, examining the infant's back, shoulders, and upper arms. Lenigo is distinct from scalp hair and eyebrow hair, which follows different developmental patterns. Fifth, breast. This assessment evaluates both the areola size and the presence of palpable breast tissue beneath it. Technique is important. Gently palpate the breast tissue between your thumb and forefinger, measuring the diameter of any breast bud present. At less than 28 weeks, the areola is barely visible or imperceptible with no palpable breast tissue, scoring -1. At 28 to 30 weeks, the areola becomes visible, stipple, and flat, but there is still no palpable breast tissue, less than 1 millimeter. At 32 to 34 weeks, the areola is stipple with raised edges, and you can palpate a breast bud of 1 to 2 millimeters diameter. At 36 to 38 weeks, the areola is larger and raised with palpable breast bud of 3 to 4 millimeters. At 40 to 42 weeks term, the areola is full and raised 5 to 10 millimeters with breast tissue of 5 to 10 millimeters. In postterm infants, breast tissue exceeds 10 millimeters. These assessments should be performed gently to avoid tissue damage, and it's important to note that breast tissue development can be influenced by maternal hormones, potentially causing slight overestimation in some cases. Both male and female infants are assessed identically for this parameter. Sixth, genitals. Sexual differentiation is assessed differently for male and female infants. For males, at less than 28 weeks, the scrotum is flat and smooth with no rugae, and the testes are undescended, located in the inguinal canal or abdomen, scoring -1. At 28 to 30 weeks, the scrotum shows faint rugae appearing with testes still high in the canal. At 32 to 34 weeks, testes are descending into the upper scrotum and rugae are becoming more prominent. At 36 to 38 weeks, testes are down into the scrotum, though perhaps not completely to the base, with a good rugae development covering much of the scrotal surface. At term 40 to 42 weeks, both testes are fully descended into the scrotum with a deep extensive rugae covering the entire scrotal sac, giving it a pendulous appearance. For females, the assessment focuses on the relationship between the labia majora and labia minora, reflecting subcutaneous fat deposition. At less than 28 weeks, the clitoris is prominent and labia minora are widely separated with labia majora barely visible. The clitoris and labia minora are completely exposed. At 30 to 32 weeks, the labia majora developing but small, still not covering the labia minora and clitoris. At 34 to 36 weeks, the labia majora nearly equal in size to the labia minora, providing partial coverage. At 38 to 40 weeks, the labia majora are larger and almost completely cover the labia minora and clitoris. At full term, 42 weeks, the labia majora completely cover the clitoris and labia minora with only thin midline opening visible. When examining genitalia, always maintain appropriate technique, gentleness and professional demeanor. It's worth noting that genital appearance can be affected by breech presentation, birth trauma, or edema, which may temporarily alter scoring. Taken together, these six physical maturity parameters provide objective anatomical markers of fetal development that complement the neuromuscular assessment. Unlike neuromuscular signs, physical maturity characteristics are generally not affected by infant behavioral state, sedation, or illness, though they can be influenced by intrauterine growth restriction or maternal conditions. Understanding the scoring methodology is essential for accurate assessment. Regarding individual component scores, each of the 12 new Ballard score items, 6 neuromuscular and 6 physical, is assigned a specific score. These scores typically range from -1 to +5, reflecting the observed level of maturity for that particular parameter. For calculation of total maturity score, The total maturity score is derived by summing all individual component scores. This provides an overall quantitative assessment of neonatal maturation. The numerical range of the total score spans from -10 to +50. For conversion to gestational age, the total maturity score correlates with standardized conversion chart to estimate gestational age in weeks. As you can see on the graph, there is generally linear relationship between increasing scores and advancing gestational age. A score of -10 corresponds to approximately 18 weeks gestation, while a score of 50 correlates with approximately 45 weeks gestation. The mathematical relationship and variability demonstrate high inter-rater reliability with interclass correlation coefficient ranging from 0.96 to 0.97 among trained clinicians. Optimal accuracy is achieved within 48 hours of birth. However, it is important to note that accuracy can be affected by the infant's clinical condition, including factors like illness, sedation, or neurological compromise. Every clinical tool has strength and limitation. Let's review this objectively. Key advantages include: first, speed and ease of administration. The assessment can be completed rapidly at the bedside without specialized equipment, making it highly practical in diverse clinical settings. Second, high accuracy. Compared to the Dubovitz method and older version of the Ballard score, the new Ballard score demonstrates superior accuracy, particularly for extremely preterm infants. Third, broad applicability. It serves as the sole viable measures when other methods fail, including situations with uncertain dates or lack of prenatal care. Fourth, non-invasive assessment. The examination requires no laboratory test or imaging, minimizing infant stress and resource utilization. Limitation and challenge must also be acknowledged. First, it is time sensitive. The assessment is most accurate when performed before 96 hours of life, with validity declining after 7 days as postnatal adaptation occurs. Second, subjectivity and inter-rater variability. Despite standardization, some components require subjective interpretation, leading to potential examiner-dependent variation. Third, influencing factors. Sedation, illness, and neurological condition can artificially lower neuromuscular scores, leading to underestimation of gestational age. Fourth, specific population. The score has limitation in small for gestational age infants and very preterm infants below 26 weeks, where accuracy may be compromised. The comparison table highlights how the new Ballard score balances accessibility and accuracy, though ultrasound remains the gold standard in the first trimester when available. As we conclude, let's review key findings and evidence-based recommendation for optimal use. Importance of trained examiners. Formal training is absolutely essential for standardized interpretation and reproducibility. This is particularly crucial for subjective signs like the scarf sign, where examiner experience directly impacts scoring accuracy and clinical utility. Integration with other clinical data. The new Ballard score should never be used in isolation. For optimal accuracy, it must be combined with the maternal obstetric history, infant weight, length, and head circumference measurements. This multimodal approach provides the most reliable gestational age assessment. Best practices for accurate assessment: always perform the examination when the infant is quiet and stable, avoiding periods of agitation or immediately after feeding. Remember that highest accuracy is achieved within the first 48 hours of life, so timing is critical for optimal results. Awareness of limitation and biases. Clinician must recognize that there can be bias toward overestimating gestational age in full-term infants in some settings. Additionally, the score is less sensitive for preterm infants than early ultrasound dating. Finally, be aware of significant limitation when assessing low birth weight infants, where growth restriction may confound maturity markers. By understanding this consideration and applying the new Ballard score judicially within a comprehensive clinical assessment framework, we can optimize its utility in neonatal care. Thank you for your attention, guys. The new Ballard score remains an invaluable tool in neonatal assessment when applied appropriately by trained clinicians. I encourage you to continue developing your skills in this assessment and to integrate it thoughtfully with other clinical data. Your feedback matters. If you found this presentation helpful, please like, share, and subscribe to the Docsaab's Diary for more educational content. Thank you and best wishes in your clinical practice.